Well, hello, and thank you for joining me. In this practice inspiration, I'll be sharing clear aligner biomechanics. I'm Dr. Marta Baird. A little bit about my background. I have a private practice in Pleasanton, California, where I practice 3 days a week. I also teach a day a week at the University of the Pacific, Arthur A. Degoni School of Dentistry, where I teach principles of clear aligners and principles of orthodontics. I'm also an Align faculty, and this presentation is supported by Align Technology. So the objectives for this session, we'll be reviewing some biomechanical principles of tooth movement and how they apply to clear aligners, how to identify causes and avoid side effects with clear aligners, as well as identify pitfalls in clear aligner design that will result in unwanted intrusion, tipping, rotation, and root movements. If we think about fixed appliances, which is where a lot of our orthodontic knowledge comes from, we're thinking about a wire inside of a bracket slot. As we engage the wire, we're thinking in terms of first order rotations in our initial wires, followed by second order movements, vertical movements, aligning the teeth as we build our way up through wires, and finally third order movements such as torque once we get into heavy rectangular wires. And we move in that fashion as we treat our patients with fixed appliances. When we think about clear aligners, it's a bit different. Not only do we have attachment surfaces that we can push on, but now we have the entire surface of the tooth, the incisal edge, the mesial and distal surfaces sometimes, the buccal and lingual surfaces. So now we're pushing on an unlimited number of surfaces, and we can take advantage of that when we're thinking about how we can move teeth, as well as being able to perform certain movements like torque and rotation at the same time. I'll spend a little bit of time discussing whether or not we should do some of those movements all at once in order to make sure our treatment tracks. But we do have the possibility of engaging on multiple tooth surfaces. We also have the ability to treat patients such as open bites by intruding teeth a bit more effectively than we can with fixed appliances because we have occlusal coverage. So in this example, I have a patient with an anterior open bite. In my digital mock-up, I intruded the posterior teeth, as well as a little bit of anterior extrusion. And as you see my patient's actual outcome, I really did achieve the intrusion that I planned in my workup. So that posterior occlusal coverage provides excellent vertical control. Another consideration with aligners is when we traditionally do class 2 mechanics for our patients, we expect to see about 5 degrees of proclination when we run elastics. Well, when it comes to clear aligners, they provide excellent coverage and protection from unwanted tooth movements. Here's a superimposition of a patient that was treated that was class 2 with class 2 elastics. And as you can see, very minimal proclination of the lower incisors during her treatment. So those multiple tooth surfaces in contact with the aligner and the tooth engaging provide a bit of more safety. If you didn't plan it in your treatment plan, it usually won't happen. The only side effect of clear aligners really is unwanted intrusion, and that's one of the things that we're looking to avoid. Well, what about this type of patient? This might seem like a simple case. The patient has a nice posterior occlusion with some anterior spacing. Here's my digital mock-up. I'm planning anterior retraction to close those spaces. And here's my actual outcome. Now I'm hiding all the attachments, and we're going to spend a little bit of time discussing those. Because when we're moving teeth, simply because we plan to not move one section of teeth, doesn't necessarily mean that those teeth won't move. As we know, the clear aligner extends from molar to molar, and so if we're applying pressure on the anterior teeth, the posterior teeth might feel a force as well. But we can be selective about which teeth we want to move if we have a patient with implants or a bridge that we'd like to choose not to move. Another advantage of clear aligners is that we may not be able to have the ability to do this in a traditional fixed system is in a patient that has recession, say the patient has recession on tooth number 23, and we don't want that tooth to come forward at all. We have the option to not allow that tooth to round trip, not allow it to procline during treatment. So while I programmed IPR to go from molar to molar in this case, what you'll see is I staged the IPR to be posterior first, That would retract the canine and then anterior alignment. So as you see, that lower incisor never had the opportunity to procline and have further recession during treatment. So we can customize the tooth movements, and they can provide us anchorage or provide us the support that we need when we have periodontally compromised patients. So when we think about tooth movement, we have, say, a single force coming from the buccal. What happens when we have a single force? Well, Newton's third law tells us that for every action, there's a reaction. So the adjacent teeth will feel some force. And if you're looking at this system and you wonder, do I need an attachment for it? Probably not. How far should we stretch the material? It depends on what system you're using. So in some systems, it's 1/4 millimeter per stage. And then how many stages? You divide up the amount that you need to move the tooth. Say you have a limited case, the tooth is out of alignment by 1 millimeter. It might take you 4 to 5 aligners in order to achieve that movement. But now consider that same movement from this view. You have a single force. There is a center of resistance on that tooth, and that center of resistance will move in the direction of the force, but there's also a tendency for that tooth to rotate because a single force creates a moment of the force. That results in the incisal edge tipping lingually, as well as a relative extrusion for that tooth. So that's something you need to think about when you're performing IPR and retracting, or when you're closing spaces, the bite may tend to deepen. So it's something we need to think about and plan for in our digital workup. And when we have a force from the lingual, it can be advantageous in our deep bite crowded cases, as we have a single force, tendency for the tooth to rotate, the tooth tips forward, and you have a relative intrusion. So if you're working on a deep bite, crowded patient, would you perform IPR at the beginning or would you perform it at the end? I would encourage you to perform IPR at the end after you've leveled the deep bite and resolved the crowding. That prevents that relative intrusion that IPR and retraction causes. Let me show you an example of a patient that I needed to consider what would happen as I retracted her incisors. So we have the initial, the digital mock-up with maintaining the posterior occlusion, and we have the clinical outcome. So some of the things that you'll need to think about is for every action, there is a reaction. So there's retraction of the incisors, and as a result, the molars are also feeling an equilibrium force. So while they are your anchorage teeth, they are still experiencing a force. There is a tendency to rotate. So if we don't place some sort of anchorage attachment on the posterior teeth, your posterior teeth may tip forward. This might look like a posterior open bite to you. It may be caused by an anterior interference, but it may also be caused by the posterior teeth beginning to be unsettled. So this is what I did for that patient. I placed posterior anchorage attachments. Those are preventing the posterior teeth from having unwanted side effects as I'm retracting the incisors. In addition, I needed to make sure that as I retracted, I also added intrusion to those upper and lower incisors. That would avoid the teeth tipping lingually and causing an anterior interference. So as you see in my digital mock-up, I actually have a void between the upper and lower incisors of about 1.5 millimeters. And then in the clinical outcome, it's just right. The spaces are closed and the patient has good overbite and overjet. Here are some clinical photos of that patient. You can see nice posterior occlusion in the initial, and then our final outcome, spaces are closed, midlines are on, and I was able to retract those incisors and open her bite. And here's her posterior occlusion. It's still nicely settled. So now let's talk a little bit about attachments. What are attachments and what are they for? If we're planning on intruding an entire section of teeth, then there's a reaction force on the posterior teeth. So you may be aware that you need to place some retention attachments on the premolars in order to intrude lower incisors in a deep bite. Well, what if you have a case where one lower incisor needs more intrusion than the others? Well, now those teeth next to it may need some retention in order to support that. What if one of the incisors has a chipped incisal edge, and while they're all intruding, one needs to intrude less? Well, now that tooth is relatively extruding compared to the adjacent teeth. So you may want to consider a retention attachment on that tooth. So if you're intruding a single tooth or intruding a section of teeth, those adjacent teeth need to have some retention attachments. Well, what about extrusion? So you may be aware, is a fundamental component of aligners is they can only push. So if you're trying to extrude a tooth, you need to build a surface on that tooth called an attachment in order to provide that contact for the aligner in order to extrude the tooth. Well, what about a rotation? Don't you have a buccal and a lingual surface that would allow that lateral to rotate? Well, with laterals, we have a tendency to see some intrusion and some tracking issues with laterals with their rotations. And so here's a paper that illustrated that point. Anywhere where the aligner interferes with the tooth, the force on that tooth is perpendicular to wherever it's contacting. So they looked at the net forces on a tooth when you're rotating an incisor. Turns out the net forces are in an intrusive direction simply because of the anatomy of that tooth. So as a result, we need to make sure that we place an attachment on any tooth that's rotating, not only to support the rotation and give the aligner somewhere to contact for that rotation, but also there's a bit of an extrusive component to this attachment. So you can see here the angle of that engagement of the aligner in the tooth. There's a vertical component to it as well as a rotation. And that prevents that lateral from intruding as it's being rotated. Now, you may be familiar with this chart. Maybe some of those orthodontists in the audience remember seeing this during residency. But what this is telling us is if we'd like to translate a tooth, we know that we can't do it with a single force. A single force creates a tendency for that tooth to tip. If we need bodily movement, then we need to also administer a rotation in the opposite direction in order to allow the tooth to bodily move. So let me show you what that looks like. A single force, tendency to tip. Now, if we want to counteract that moment of force and we don't want uncontrolled tipping, maybe we'll place a small counter moment. A small counter moment will still have a tendency to tip, but now the center of rotation is around the apex. That's called controlled tipping. Well, if we want bodily tooth movement, we need to make sure that that counter moment can balance out the moment of the force. So as we're bodily trying to move teeth, we need to make sure that we're using attachments and perhaps building in that counter moment into our treatment plan. Well, what about expansion? A single force causes a tendency for the tooth to rotate. And so if we have expansion built into our aligner system and we're not counteracting that tendency to rotate, you may start to see a posterior open bite. So we need to make sure we've not only built an attachment on the buccal surface, but perhaps we've built in some extra buccal root torque at the same time that we're expanding in order to create that counter moment. So what kinds of things might cause the force from the lingual to increase that might be cause that force to be too high in order for the counter moment to balance it out? Well, if you build in a lot of over-treatment of expansion in your digital mock-up, you may have a plan where there's just too much force coming from the lingual that there's no way for that torque to keep up. Or if your patient is changing their aligners too quickly, that might cause this, especially if they're not wearing their aligners enough hours. Every time they put that tray in and they say, oh, that's tight, that's a force that's causing those teeth to move buccally. They may not be wearing their aligners enough time for you to see the root to move along with the crown for that bodily movement. Because what would happen? You would see that tooth would tip. And as a result, the lingual cusp would be interfering, the buccal cusp would lift, and you would see a posterior open bite. So clinically, many posterior open bites are not just anterior interferences, but also posterior interferences and buccal cusps that have lifted due to expansion without the right mechanics. So what do? We don't want to push harder. We want to reduce the force of expansion and instead add some intrusion to the lingual cusp, add some extra torque to the molar, and make sure we have an attachment on the buccal. So when it comes to things that I have run into that have unfortunately increased the number of aligners I need to order or additional modifications, scan quality is number one. So I'm not using PVS, and maybe many of you have scanners in your practices. Have you ever run into a situation where you have your initial, you have your digital mock-up, and now you're working on your next series of aligners? Do you see that second molar? That second molar was not captured in the scan for the additional aligners. And so I didn't notice that in my workup. And that actually ended up causing an additional series of aligners as that tooth moved without control. So if second molars are erupted, make sure they're fully scanned and included before you proceed with working on your digital workup. Pitfall number 2 that I'd like to discuss are missing retention attachments. So in this example, this patient has a situation where there's an anterior open bite as well as a transverse discrepancy. So in my treatment plan, I'm performing torque on the second molar. But how is the aligner going to push in order to get that torque to happen? What I was missing was a retention attachment on that second molar. And so I went back and looked what would happen if I didn't use a retention attachment, what happened in this case. And as a result, the tooth came lingually. I didn't get the torque. It just came lingually and tipped lingually. And that created a new transverse issue that I needed to address. So if you have movement on a molar like torque or expansion, make sure you have some type of attachment on there to help lock the tray in. So as a result, the way that I recovered, I placed an attachment on the buccal and the lingual. I performed a little bit of constriction on the lower arch, and I added more torque in the upper arch. So as a result of that movement, my clinical outcome showed I was able to get that second molar settled back in with that movement. Pitfall number 3, expansion mechanics. There are many things that can go wrong when we're expanding. One of those is missing attachments. So in this patient's example, I was very focused in on the class 3 on the right side. Patient had an anterior crossbite and a class 3. And I missed this. I missed placing an attachment on my second molar. So here is my digital mock-up. And you'll see that second molar was expanding without any additional buccal root torque or mechanics to support that. So here's my digital mock-up and here's my clinical outcome. Now I need to go back, make sure I have attachments on those teeth, add extra torque. So make sure when you're checking your digital mock-up and you're about to approve it and move to the next phase, if you have any type of transverse movement on the molars, that it's supported with an attachment and additional torque if you're doing expansion. Well, pitfall number 4 is unwanted root movements, because sometimes you can't quite tell what's going on under the surface. So here is an example, a patient that was ready for an additional series of aligners, and there's some movement. Okay, it'll play again in just a moment. Now watch the second premolar. If you look at the tooth movement table, that second premolar has 7 degrees of mesial root tip. And I did not catch that at the time that I approved this case. I used attachments, allowed all the default protocols, and I missed that tip on the premolar, excuse me. And notice the patient's initial panoramic x-ray, how parallel her roots were, and look at what excellent root control I had with my root control attachment, but it's an unwanted side effect. It was a root movement that I should have removed from my treatment plan, my digital mock-up. So be sure to look at the angulation changes on your posterior teeth. And if it makes sense to keep it, then keep it. And if it doesn't make sense in your treatment plan, then make sure you take away unwanted root movements. That includes unwanted root movements in maxillary laterals, because sometimes the setup is placed based on the incisal edge, not necessarily where the roots are. And if you have a chipped incisal edge, software may not calculate the long axis of the tooth correctly. So moving on to pitfall number 5, subthreshold movements. So when it comes to subthreshold movements, they're those little subtle movements that you may or may not need an attachment for. But as you look at this patient's digital mock-up, we're going to focus on the lower incisors. And the lower incisal edges are a little uneven and they're all intruding. So this is similar to what I mentioned at the beginning, where you may want to place some retention attachments on those lower incisors in order to make sure that the aligner engages, and that if there's a large rotation on the canine, the aligner's not going to pull away from the lateral and cause some unwanted side effect. So it's always helpful to add a few more retention attachments, especially on laterals or the teeth that you find you lose tracking on. Make sure that you've got something to hold that aligner in place. So in summary, ensure that all the teeth are included when you're scanning. I know it sounds so simple, but we get so busy in our clinical day, we may not be double checking that. Make sure that you're using retention attachments. They're not just for deep bites. They are great for incisor retraction, posterior expansion, intrusion of adjacent teeth, and then subthreshold movements, and then make sure that you're removing unwanted movements. If you are taking off an attachment, think about, why was that attachment placed there? Is there some movement that you're not seeing that you need to take away as well as the attachment? So thank you for joining me in this practice inspiration video. If you have any questions, please feel free to email me. I have my email right here. And again, thank you for joining me.